Hello, everyone, and welcome to this new lecture of the series on fluid, electrolyte, and acid-base disorders. If you haven't done so already, please subscribe to the channel and like the videos. This series is based on my book, Manual of Fluid, Electrolyte, and Acid-Base Disorders, a pathophysiologic approach to common clinical problems. I'm Dr. Mohammad Tinawi. I'm a nephrologist in Northwest Indiana. This is the book. You can find it on Amazon. Please follow the link below. It's available as an ebook and hardcover. Both are in full color, and also there is a paperback edition. So welcome again to lecture 50. We are still on chapter 7, hypophosphatemia and hyperphosphatemia. Today we are going to start our discussion of hypophosphatemia. How do we diagnose hypophosphatemia and hyperphosphatemia? Well, we need a high index of suspicion because when you order a regular chemistry panel, phosphate is not there. If you suspect it, you can order it and any lab will do it for you. To establish the diagnosis, usually you need to order sodium, potassium, magnesium, calcium, B, and creatinine, probably PTH and 25-hydroxyvitamin D level. Now, if you need to order FGF23 assay, then you have to send that out to a reference laboratory. Usually we don't need urine phosphate unless we are suspecting renal phosphate wasting, therefore you don't order it in case of hyperphosphatemia. Now, if you are suspecting renal phosphate wasting, then measure urine phosphate, urine creatinine, in addition to serum creatinine and serum phosphate, and calculate the fractional excretion of phosphate. Normally it's 5 to 20%, but if there is hypophosphatemia, the kidneys should preserve phosphate, so it should be less than 5%. If you have fractional excretion of phosphate over 5% or total urinary phosphate of over 100 milligrams daily, then you should suspect renal wasting of phosphate. Like we said earlier, in patients with chronic kidney disease, fractional excretion of phosphate can reach up to 60%, so the kidneys are working hard and yet you still get hyperphosphatemia. Now, in the publication I have on the screen in the Annals of Clinical Biochemistry, the author suggested a better method of measuring renal phosphate absorption. You can go to that publication if you're interested. What about the manifestations of hypophosphatemia? So now let's start discussing hypophosphatemia. Hypophosphatemia can be mild if serum phosphate is 1.5 to 2.4 milligram per deciliter, moderate when it is between 1 to 1.4, or severe if it is less than 1 or less than 0.32 millimoles per liter. Now, in hospitalized patients, we see a lot of hypophosphatemia. 5 to 10% maybe of hospitalized patients have hypophosphatemia. But if you take patients coming to the emergency room with DKA, sepsis, alcoholism, then the incidence can go up to 20 to 80%. So in those patients, you really must order serum phosphate level. Mild hypophosphatemia, like mild anything, mild hypocalcemia, mild hypokalemia, mild hyponatremia, is usually asymptomatic. Now, in moderate hypophosphatemia, we can start to have problems with metabolic encephalopathy, changes in mental status, hemolysis, thrombocytopenia, even seizures, poor appetite. There's association with rhabdomyolysis and myopathy. If hypophosphatemia becomes severe, like we said, serum phosphate less than 1 milligram per deciliter or less than 0.32 millimole per liter, you can have respiratory depression, and patients on ventilators can have difficulty weaning. So in patients who are difficult to wean, order serum phosphate and replace it if needed. Now, the manifestations of hypophosphatemia are diverse because you have low ATP and low erythrocyte 2,3-DPG. Diphosphoglycerate. So phosphate is in the energy currency, if you will, of the cell in ATP. Therefore, if you have low phosphate, you are going to have many problems. What can cause hypophosphatemia? Think of 4 things. What are the possibilities? You can have decreased intake of phosphate, poor diet, or you have decreased intestinal absorption, maybe diarrhea. You can have a shift of phosphate into the cells, like maybe respiratory alkalosis, or you can have renal phosphate wasting, like someone on diuretics. These are the 4 possibilities. So we are going to mention like 50 causes of hypophosphatemia, but each cause is due to one of these 4 possibilities or more than one, and we are going to analyze it, and it's actually fun to analyze the causes of hypophosphatemia. Most cases of hypophosphatemia are acquired, not genetic, and they are due to malnutrition, alcoholism. Genetic causes, we are going to mention those, but they are rare. Let's talk about decreased intake or decreased absorption of phosphate. Here, these are the big ones. The 3 things you see on the screen are really very common: malnutrition, diarrhea, alcoholism, and vitamin D deficiency. These things should come to mind first. So malnutrition, chronic diarrhea, steatorrhea, intestinal malabsorption are common causes of hypophosphatemia, especially when you have vitamin D deficiency. Now, fat malabsorption reduces absorption of fat-soluble vitamins such as vitamin D, and that also will result in hypocalcemia. So many times you see both hypocalcemia and hypophosphatemia. Alcohol withdrawal patients have not only severe hypophosphatemia, but have a wide range of electrolyte disorders, okay, a whole textbook. So here you can have hypokalemia, hypomagnesemia, hypocalcemia, hyponatremia. So the nutrition is poor. You are giving those patients fluids. Usually the fluids don't have any phosphate. They may be hyperventilating in metabolic alkalosis. Their vitamin D status is poor. So for all these reasons, you are going to have hypophosphatemia. So not only do you need to replace phosphate, but other things. Never forget thiamine, okay? If you even mildly suspect if you mildly suspect alcoholism as a cause of anything, start thiamine. Don't give them D5 without starting thiamine. If they cannot take it orally, give it IV, okay? No one is going to overdose on B1. Whatever is not needed will go into the urine. So thiamine is key. Vitamin D deficiency is a very common cause of not only hypophosphatemia, but hypocalcemia. So when I see a patient with both low calcium, low phosphate, vitamin D deficiency comes to mind. What am I going to order? 25 hydroxyvitamin D level, not 125, just 25, okay? The nutritional vitamin D deficiency. So people with poor nutrition, lack of sun exposure, can have that. Now, some patients have vitamin D resistance, okay? And that decreases intestinal phosphate absorption, also calcium absorption. And when you have low calcium, you can have secondary hyperparathyroidism, and subsequently, when PTH is up, you have phosphaturia, and that will decrease phosphate further. Now, are there other causes here related to vitamin D? Yes, I'm going to mention these causes for the sake of completion. These are interesting, especially for the pediatric endocrinologist or pediatrician or pediatric nephrologist. We have to know about it, but probably in all of my career, I've seen one case. Maybe I'm not looking hard enough for it. But anyway, vitamin D dependent rickets type 1A. This is due to inactivating mutation in the CYP27B1 gene. This gene encodes the 1-alpha hydroxylase. So in this case, you are not going to have conversion of 25-hydroxy-D to calcitriol. So PTH will rise. You are going to have hypocalcemia, hypophosphatemia, high phosphate in the urine. How do you treat it? Well, calcitriol. So here you don't have enough calcitriol, so you give calcitriol. Now, the second possibility here is vitamin D dependent rickets type 1B. This is due to loss of function mutation in the CYP2R1 gene. Now, this gene is responsible for 25 hydroxylation of D. So when you get vitamin D from the sun, or you take ergocalciferol or cholecalciferol, it has to be converted by putting 25 hydroxy in the liver. If that doesn't happen, then this vitamin D precursor is not going to work. So in that case, you treat it with calcidiol or Realdi. It's available. And this is 25 hydroxy vitamin D, so it's ready to hit the ground running. It goes to the kidney and becomes activated. If you give nutritional vitamin D like ergocalciferol D2 or cholecalciferol D3, it's not going to work because it needs hydroxylation, and the problem here, they cannot hydroxylate. Now, then there is the even rarer cause of vitamin D problems, hereditary vitamin D resistant rickets. This is very rare. It's due to inactivating mutation in the vitamin D receptor gene. So the problem is in the vitamin D receptor. Now, the third cause of hyperphosphatemia is intracellular shift of phosphate. So if you have someone with diabetic ketoacidosis or non-ketotic hyperglycemia, the patients initially have high phosphate and high potassium, but when you give them intravenous fluids without phosphate and you give them insulin, you are going to have a shift of phosphate into the cells, not just phosphate, but potassium too, and you will have low phosphate and low potassium. So you have to follow these levels carefully and replace as needed. Moreover, those patients have osmotic diuresis and they're getting fluids again without phosphate, and that will aggravate the problem. TPN, usually we add phosphate to the TPN and we follow closely, but if you neglect to do that, you are going to have hypophosphatemia because the patient is not eating. Their source of nutrition is what you're giving them. Also, the insulin in the TPN will drive phosphate and potassium intracellularly. If you have increased insulin secretion for whatever reason, you are going to have a shift of phosphate and potassium into the cells. You can see that upon refeeding of patients with malnutrition, like in alcoholism or anorexia nervosa. Now, I underlined here epinephrine and glucagon because they can cause a transient intracellular shift of phosphate. Recently, I saw a case and it was very interesting, and I told the physician who consulted me that the hypophosphatemia should improve once we don't have epinephrine on board, and that's what happened exactly. So it's an interesting cause to keep in mind. Okay, we'll continue here. If we have acute respiratory alkalosis, like in hyperventilation, patients on mechanical ventilation, sepsis, salicylate poisoning is going to drive phosphate. And again, I always say that potassium into the cells. Cellular uptake of phosphate. If you have rapidly proliferating malignancy, Burkitt's lymphoma, these malignant cells are going to take up phosphate and cause hypophosphatemia. Hungry bone syndrome after a parathyroidectomy in kidney patients is going to result in severe hypocalcemia and to a lesser extent hypophosphatemia and sometimes even hypomagnesemia. So follow calcium, magnesium, phosphate and replace as needed. An interesting recently recognized cause of hypophosphatemia is cannabinoid hyperemesis syndrome. Apparently, it causes a shift of phosphate due to hyperventilation. So keep that in mind. Increased renal excretion of phosphate. You see that in primary and secondary hyperparathyroidism. Why? Again, PTH is phosphaturic. So you know that now. Post-kidney transplantation, you still have elevated FGF23 level and maybe PTH, and that is going to cause increased excretion of phosphate in the urine. Also, we said FGF23 and PTH both are phosphaturic. If you are giving diuretics, recently I saw a case of hypophosphatemia due to diuretics. If you have someone who's diuresing a lot, like post acute tuberous necrosis, the diuretic phase, and post-obstructive diuresis, also you are going to have short-lived hypophosphatemia. All you have to do is replace it. Now, less common causes, acquired Fanconi syndrome due to medications. Keep in mind tenofovir, very commonly now used, aminoglycoside, ifosfosfamide. Recently, I reported with Dr. Bastani the first case of severe hypophosphatemia due to acquired Fanconi syndrome from the checkpoint inhibitor nivolumab. I'll put a link to that publication in the description below. Now, next, this is a very interesting diagnosis. I haven't seen a case yet. It's tumor-induced osteomalacia. You have a mesenchymal tumors causing hypophosphatemia due actually to actual secretion of FGF23. So the tumors will produce FGF23. You order an assay, it's high. If you resect the tumor, the hypophosphatemia is gone. So keep that in mind. If you make that diagnosis, you'll be considered a genius. Continuous renal replacement therapy, CRRT, is common because the fluids we replace with don't have phosphate. So after a day or two, the hyperphosphatemia will convert into hypophosphatemia, and we have to give them phosphate or add it to the replacement solution. I'm going to end here, and we'll continue talking about hypophosphatemia in the next lecture. Thank you.